Thank you very much, Dr. Champlin, and thank you for the invitation to discuss about polycythemia vera during this meeting. Well, as you know, PV is a chronic MPN in which there's an unregulated overproduction of morphologically normal cells, red cells, white cells, and platelets. The only feature that is specific of PV among all the MPNs is the presence of an erythrocytosis. If you can prove erythrocytosis in an MPN, then it can only be PV. On the other hand, there's no currently a specific clonal marker for PV, as was discussed by Dr. Bestrovcek just before. You saw that even the JAK2 mutation that is present in almost all patients with PV can also be found in other MPNs. Just a definition here is that erythrocytosis means an increase in the red cell mass. And usually this is translated by an elevated hemoglobin and an elevated hematocrit, but it's not always the case. So if you do this red cell mass determination, you can define an absolute erythrocytosis if the red cell mass is elevated, and this allows you to eliminate apparent and relative erythrocytosis. However, once you prove that the patient has an increase in red cell mass, it doesn't mean necessarily PV. As you can see, you can have different causes for this erythrocytosis. First, the primary erythrocytosis. That means that there's an intrinsic abnormality in bone marrow progenitors and overproduction of red cells due to an abnormality of your hematopoiesis. And among these, PV is the most frequent as an acquired primary erythrocytosis. But there are also many secondary causes. Secondary erythrocytosis means that the bone marrow progenitors are normal and the overproduction of red cells is due to another stimulus, and these are much more frequent than primary erythrocytosis, and the most frequent causes are listed here. As you can see, they are mediated by erythropoietin that is increased because of hypoxia or a tumor that produces erythropoietin. And you also have, if you cannot define primary or secondary erythrocytosis, few patients still fall in the category of what is called idiopathic erythrocytosis. So let's discuss quickly of the biology of polycythemia vera. Over the years, since the description of the disease, many biological abnormalities were found in this disease, the most famous being cytokine hypersensitivity that was used for a long time as a diagnostic test with the presence of what is called a spontaneous growth of erythroid colonies or endogenous erythroid colony formation. But over the years, we knew in 2005 that all these abnormalities were mainly related to abnormalities in the JAK-STAT pathway, as it was shown just before, and especially with the JAK2 V617F mutation that can explain many of these properties, this hypersensitivity, the constitutive activation of different intracellular signaling pathways. But also, as it was shown just before, we know now that the JAK2 V617F mutation is not the only abnormality that can be found in PV. And the second most frequent abnormality in PV is another mutation in the JAK2 gene, in another exon that is called the exon 12 JAK2 mutation. But we have also many other mutations. Some of them are listed here, and as you can see, all of these mutations either target the JAK-STAT pathway or modify the chromatin expression of the genes, such as TET2 mutations, for example, that are found in about 20% also of PV patients. So let's discuss about the way to diagnose PV now. The most recent WHO classification selected several criteria to diagnose PV, and we'll discuss some of them. First, the hemoglobin should be elevated or the red cell mass should be elevated. These are the thresholds that were selected in the WHO classification. Just a quick discussion about these thresholds. For example, here in women, you can diagnose erythrocytosis when the hemoglobin level is above 16.5 gram per deciliter. And you can see in this study, for example, the relationship between the hemoglobin level and the red cell mass, with here the 16.5 cutoff. And you can see that the women with an hemoglobin level above 16.5, most of them have also an increased red cell mass. But if you look for patients who have less than 16.5 of hemoglobin, you see that a large proportion of them still have an elevated red cell mass. This doesn't mean that you need to do the red cell mass for all patients to diagnose PV, but just you have to be aware that you can miss and overlook some early stages of PV patients if you only look at the hemoglobin level. Another situation where this hemoglobin level is not relevant to diagnose PV is the presence of a splanchnic vein thrombosis, portal vein thrombosis, or Budd-Chiari syndrome. You can see here in a study of 241 patients that the patients with the JAK2 mutation, that means that they have an MPN, had almost normal blood cell count, an hemoglobin level that was 13 in median, hematocrit median was 43, and platelet count also was always normal. And this is due to portal hypertension, hypersplenism that is very frequent in those patients with a splanchnic vein thrombosis. And when you screen those patients for the JAK2 mutation, when they are positive, you see that PV could be diagnosed in the majority of those patients with the JAK2 mutation and only by doing the red cell mass assay. Otherwise, the blood counts, and especially the hemoglobin and hematocrit, were completely normal. So the second major criteria to diagnose PV, once you have established that the patient has too many red blood cells, is to find a clonal marker, JAK2 mutation, or another mutation. And I won't go into the details, just to show you here that the most frequent mutations in polycythemia vera patients are JAK2 mutations, including V617F for about 95% of those patients, and the rest of the patients is usually positive for those other exon 12 JAK2 mutations. So with these two mutations, virtually all PV patients have a JAK2 mutation, but as you can see, they can also have other mutations, and these mutations, none of them is clearly specific of PV, can be found in PMF-ET and even in other myeloid or lymphoid malignancies. So you need those two major criteria, an erythrocytosis and one characteristic mutation, and you also need to have some minor criteria, including the bone marrow histopathology, or a low serum EPO level, or the presence of those endogenous erythroid colony formation from bone marrow progenitors. Just to discuss about those bone marrow changes, there are specific histopathological features for polycythemia vera, as you know, but I think an interesting set of data was produced by the international group recently, showing that if you have some degree of fibrosis in the bone marrow of PV patients, this may have a prognostic impact regarding the progression to myelofibrosis and also the survival without thrombosis. So therefore, this bone marrow evaluation probably is not required in all patients to make the diagnosis of PV, but may have an impact for their prognosis. So in whole, we can summarize the way to diagnose polycythemia vera this way. Now it's very simple and rapid. You just need 2 blood tests. One is screening for the JAK2 VF mutation, and the other the serum EPO level. If the patient has the JAK2 VF mutation and a low EPO level, then you can diagnose PV. If the JAK2 VF mutation is negative and the serum EPO low, then you can look for the exon 12 mutation, and usually you find one of these 2 mutations. Bone marrow biopsy, again, can be performed either to confirm the diagnosis or to have some data for the prognosis of those patients. So now let's talk about the evolution and prognosis of polycythemia vera. Although it's a chronic MPN and less aggressive than CML, obviously, this disease also has an impact on survival, and there's a loss of life expectancy that has been shown in many retrospective studies, for example, as in this one from Francesco Passamonti. What are the causes of death of those patients? I think the very interesting data came from the ICLAP, a European study that included 1,600 patients, PV patients, but with a short median follow-up that was about 3 years only. And you see that 164 patients had died, and the main cause of death on this relatively short term was cardiovascular causes, either myocardial infarction or a stroke. Cancer was the second cause, and hematological transformation to myelofibrosis or acute leukemia in 13% of patients. So the short-term risks are mainly cardiovascular and are mainly thrombosis. There are some risk factors that have been validated in several studies for this risk of thrombosis, and there are only 2 and very simple because you can have them only by seeing the patient. You don't even need a sophisticated test. It's an age above 60 or a history of thrombosis. With these 2 factors, you can define patients at high risk to develop thrombosis, and therefore it will have an impact on their therapy. There are also possibly new markers and risk factors for thrombosis or survival, such as leukocytosis. We have several data suggesting now that leukocytosis is an important risk factor for developing thrombosis, but also we found that in a phase 2 study several years ago, leukocytosis could be a risk factor for poorer survival and higher risk of transformation to acute leukemia. There are also some data I will show you after to say that the level of the JAK2 mutation, the burden, what we call the allele burden of VF mutation, is of importance to diagnose, especially or to maybe associated to a higher risk of evolution to myelofibrosis, and more recently, the prognostic role of inflammatory markers such as hypersensitive CRP, for example, has been also suggested as marker for thrombosis. But until now, only these 2 very simple and clinical factors are validated and should be considered in clinical practice to decide the therapy of your patients. Now, what about the long-term risk? As I mentioned before, from the diagnosis and going up for a long time, the main risk is thrombosis. But after 6 to 10 years of evolution, you see that appears then a risk of transformation to myelofibrosis and leukemia that increases over time without clear evidence for a plateau. And I will show you just the results of one randomized trial that was performed in France that randomized hydroxyurea versus pypobromine in PV patients younger than 65 years. The first results were published in 1997 in Blood with a median follow-up of 9 years. And you can see that at that time, 13 leukemic events were recorded in the study with a cumulative incidence that in the range of most retrospective trials or trials with less than 10 years median follow-up of about 10% at 13 years. But we could update all the patients for this of this trial in 2008 with a median follow-up of more than 16 years. And you can see the dramatic increase in the number of leukemic events observed from 13 to 51 transformation, including 41 acute leukemia and 10 myelodysplastic syndromes. And the cumulative incidence at that time with this final analysis was 25% at 15 years, 34% at 20 years. You can see here this cumulative incidence, and if we focus only in patients treated in the hydroxyurea arm, you can see that this incidence was about 16% at 15 years and 24% of evolution to acute leukemia or MDS after 20 years of observation. In this prospective trial, we could also find for the first time that the median survival of those patients was clearly decreased compared to the expected life expectancy, with a median survival of 17 years for the whole cohort and 20 years for the patients treated or randomized in the hydroxyurea arm. And when we looked at the causes of death in this trial, you can see that it's quite different than what is described in the ECLAP trial with shorter follow-up. Here, with a very long follow-up, more than 15 years median follow-up, you see that the first cause of death was evolution to acute leukemia or MDS. Half of the deaths were due to such evolution. And this is completely in line with another trial we published several years ago. Again, in patients with polycythemia vera treated with piperbromine, you can see that when we analyze the causes of death, again, after more than 10 years of median follow-up, you see that 1/3 of patients died of acute leukemia. And when we looked for patients, especially younger than 60 years at diagnosis, you see that leukemia was, again, the cause of half of the death of those patients. So these results suggest that the main long-term concern for PV is not thrombosis, but mainly evolution to leukemia, now that we have several drugs, cardiovascular drugs like statins, etc., that clearly improved the risk of thrombosis and dying of thrombosis. So maybe the main concern for those patients on the long term is to avoid evolution to leukemia. They can also evolve to myelofibrosis. These are the figures. As you can see in the hydroxyurea arm, the cumulative incidence of evolution to myelofibrosis was about 24% at 15 years, so this is not also negligible. And as I mentioned before, we have now some data indicating that the high V617F allele burden in PV is probably a risk factor for developing myelofibrosis during follow-up, as shown, for example, in this study by Francesco Passamonti. So in all, it's clear that in PV, you have, on the short term, a vascular risk that is the main problem, and you should do everything to avoid thrombosis in those patients, arterial, venous, and also hemorrhage. But on the long term, there's clearly an hematological risk of evolution to myelofibrosis or acute leukemia, and the management should be a balance to avoid those thrombotic events on the short term and also minimize the risk of evolution to acute leukemia on the longer term. So how can we translate that for the therapy of PV patients? I have summarized here the recent recommendation by the European Leukemia Net. You can see that we have these two risk factors that can define low-risk patients who are both younger than 60 and never experienced vascular events in their history, and high-risk patients who have one or two of these risk factors. For all patients, it's recommended to use low-dose aspirin, since the ECLAP study showed that this was able to reduce the vascular risk. Low-risk patients then should be treated only with phlebotomies, and high-risk patients require cytoreduction. And what is new in this recommendation is that either hydroxyurea or interferon alpha are recommended as first-line therapy. Of course, in all patients, an aggressive management of cardiovascular risk factor is very important. So as I mentioned, what is really new in this recommendation is that interferon alpha can be proposed as first-line therapy. Why? We have two phase 2 studies that supported this recommendation. This is the French study. It was a phase 2 study of pegylated interferon alpha 2A that showed several new results that were shown at ASH last month, that after more than 75 months median follow-up, we had 80% of the patients were still in complete hematological response on the long term. More importantly, 38% of the patients in this trial were still in clinical remission after having stopped PEG interferon alpha therapy for a median duration of more than 28 months, and no vascular events was reported. And this was also found in a sister study at the MD Anderson, which showed almost the same kind of results, at least in clinical and hematological response. The possible advantages of interferon alpha in PV are that first, the two studies have shown that this drug could reduce the MPN clone as assessed by the measurement of the JAK2 mutation. This drug can induce clinical remissions after cessation of therapy, and you can stop in some patients after 2 or 3 years of use of interferon, and the patient remain in clinical remission. Maybe they have lower incidence of vascular events, and our hope, of course, is that this drug may alter the natural history of MPN because it's able to induce clinical remissions, molecular complete remissions, and also histopathological remissions. But we have other ways to treat those patients, maybe, and that it was mentioned before. You can target the JAK2 that is overactive in those diseases, but also you can target the mutations that modify the expression of genes with histone deacetylase inhibitors. Here are the results of a JAK inhibitor, the ruxolitinib in ET and PV, that were presented by Dr. Verstovsek before. This drug can control the hematocrit in more than 80% of patients over time, can also reduce the spleen size and improve the symptoms, just like in PMF. And there's currently ongoing a large phase 3 study in patients with polycythemia vera who are resistant or intolerant to hydroxyurea that will probably show, or hopefully show, that this drug can be useful as second-line therapy. But there are other trials, other drugs ongoing in polycythemia vera. For example, with this other JAK inhibitor, there's also a trial in PV patients resistant or intolerant to hydroxyurea. There's also a trial with this HDAC inhibitor, Givinostar, in combination with hydroxyurea. So hopefully we will have new drugs for patients who are resistant to hydroxyurea. So in conclusion, we have many new data in PV, new mutations, new criteria, new risk assessments, new drugs, etc. But maybe it's still too early to clearly change PV management, except that hydroxyurea or interferon can be used as first-line therapy. It's clear that the diagnosis of PV has become much more easier. If you have just this JAK2 mutation and a low EPO level, you're done with the diagnosis. What is important, in my opinion, is that with the better management of generic cardiovascular risk factors in the recent years, hematological transformation could be the main concern on the very long term, and especially in younger patients at diagnosis. And the new data with interferon and the novel therapies have resulted in a very large number of clinical trials in PV, and I'm very happy of that because this disease was neglected for many years before the discovery of the JAK2 mutation. And I thank you very much for your attention.
Yeah, so we're running behind, so I just have one question. So this would seem to be a logical disease where a JAK2 inhibitor would be a, sort of the preferred therapy. Do you think this is going to emerge as the treatment of choice?
I don't know. There are the concern that Sir just raised before about the eradication of the disease. I don't know if it can be achieved with these JAK inhibitors in polycythemia vera. We will know maybe more with the clinical trials, and also there's a concern about the durability of those responses once you stop therapy. So these will be the two questions to answer before suggesting that these drugs will change the history of those diseases.
Okay, thank you.
Thank you.